Welcome to Chapter 3, Human Development. So, our lecture does not really track the book this week. This is a whole bunch of news you can use, but it isn't really around your reading. I picked the things that I thought were kind of mission critical to like being a human being and decided to focus on those things. Your book does a perfectly adequate job of doing everything else. Of course, you need to make sure that you know what is in the book. This is also very important information for you. Okay, so let's talk about physical and prenatal development first. By the way, this particular lecture is going to go by fairly quickly. And if you have additional questions, by all means, please do ask. Okay, so what is development? It's the systematic physical, cognitive, and social changes in the individual that occur between conception and death. So, in other words, we think about development as childhood development, but it's not just childhood development, it's a lifelong process. That being said, it certainly starts with being a child or not being born yet. Okay. So, as you knew already and learned in more depth last week when you covered the Dutch famine, there are several risk factors for unborn children. There are more categories than this, but they fall mainly into parental age, not just maternal age, that's mom, um, maternal nutrition, that is mom, teratogens, which we'll cover that in a second, but it's basically toxins, and physical trauma. So let's talk about those one at a time. Before we do that, though, I want to make a recommendation to you if you are expecting or would like to be a parent in the future. I highly, highly recommend Expecting Better by Emily Oster. She has multiple other books that cover other parts of parenting, but Expecting Better is about being pregnant. And it's a really, speaking as somebody who has been pregnant and was sort of confused by the huge array of books that were available and possible to read, I really think that this is a really good place to begin, especially if you're somebody who believes very deeply in evidence and in science. Emily Oster, it doesn't get any more evidence-based than her. Okay. So let's talk about parental age first. We'll talk about mom's age, start there. The main concern here is about fertility and chromosomal defects, which are two different things. So fertility is, can you get pregnant, right? And there's this thing, if you look at the bottom of the slide, called the fertility cliff, which is this idea that after the age of 35, fertility just falls off a cliff. Like you might as well not even try. And that is not the case. The fertility cliff does not exist. It is true that as you get older, fertility decreases, but it's not like some huge cliff that you fall off of. Basically, like, from the minute you start decreasing in fertility, I believe it's around age 24 or something like that. Like it's a pretty steady decline. It gets a little more rapid at certain points along the way, but like it's not a huge drop off. So that's kind of a myth. The other thing we should talk about is chromosomal defects. So maternal age is a known risk factor for chromosomal defects. So Down syndrome comes to mind. The risk does increase, but again, it's not like this big giant cliff. And also, it's very important to kind of keep in mind what the actual risks are. So they are they're just small at any age, right? The percentages, if you do the math on what the percentages are, like the reason why they're not presented here as percentages is because they're so small as to not be meaningful, right? So 103, 374 for a maternal age of 35 is pretty small. It's not as small as 1 in 1400, but it's still pretty small, right? So I just wanted you to think about that. Okay, so paternal age. So now we're talking about dad's age. And if you're surprised that this is an issue, you are not the only one. Lots of people are surprised by this. And it's not as well studied. There are a lot of social factors around why it's not as well studied. But there seems to be some connection between paternal age and the risk of autism and ADHD. And the work is flawed. The research is not perfect. And I want to kind of respect our previous conversation around good science and what good science is and what it means to do good science. I do want to spend just a little bit of time discussing why the work is flawed. So first of all, it's really difficult to pull the variable of father's age apart from the variable of mother's age. And if you think about that, it kind of makes sense. People who are similarly aged tend to have children together. So it's very difficult to disaggregate those variables. And also, like the window of childbearing age is for women is about 30-ish years, basically, more or less, give or take. And it's just very difficult to uh, take these two things separately. The methodology that you would need to do that would require a very large sample size of men who um, are, not to put too fine a point on it, quite old in comparison to the childbearing parent. And the sample size needed to make any sort of conclusions, the logistics around creating that would be very, very difficult. So it's very hard to do that. And so to the second point, men who have children older have other variables that set them apart from men who have children younger. The same problem, right? So like, for example, if we're talking about men who are much, much, much older than their partner who is bearing the child, there are other characteristics of that situation that have bearing on this topic and any other topic that might be studied, right? So they have other variables. So the methodology for the strongest association between age and autism ADHD required that the scientists compare the children of older fathers who had children with multiple mothers. Oof. Okay, so a later born child of a father who has multiple children with multiple partners is more likely to be diagnosed with ADHD. Well, I mean, sure, that's true, but that's correlational, right? That is not scientific evidence. And the difficulty with that is that there are many, many, many complicating factors in this situation that are not just how old dad is, right? So let's look at that again. A later born child of a father who has multiple children with multiple partners. So there's a lot of like social stuff going on just in those 5 words: multiple kids with multiple partners. Right. So lots of stuff going on there. And so the fact that those later born children are more likely to be diagnosed with ADHD, it's very hard to pin that on paternal age. Right. So there's a link on Canvas to help you read more about this and the issues with the research. Okay. So maternal nutrition. So there's There's really strong research. I just want to give you the sidebar first. There's really strong research that shows that what the mother eats during pregnancy influences the taste of the child years down the road. That's actually really important research. Please, if you are a pregnant person, go eat a variety of things, the best that you can, ideally healthy ones, because it really does influence the tastes of the child that you bear. And that has knock-on effects for their health in multitude ways. So just keep that in mind. So there are two big deal things when it comes to maternal nutrition. And like kind of in general, try to eat as healthily as you can and as diverse a set of items as you can, see sidebar. Um, if you experience the signs of a deficiency or a developing deficiency of anything, talk to your doctor. So like, I had some issues with restless legs while I was pregnant. This is very, very common for pregnant women. And I solved it with a supplement of magnesium and potassium right before bed. And so like clearly my body was saying that I was developing a deficiency, right? Or had a deficiency. And it was very simple to solve. So, reach out to your doctor. One of the most um common symptoms of iron deficiency is pica. Okay, so the definition of pica is the craving or the actual eating of something that is not technically food. This includes ice. So, people in general, I'm just going to talk about people now who are deficient in iron will often crave ice. Not sure why. But if you find yourself spending a lot of time crunching ice while you are pregnant or even while you're not pregnant, you really need to go get your iron levels checked. Okay. So in pregnancy, your blood volume increases 45%. That's a lot to support the fetus. And you need iron to make blood cells. So it is very, very easy to become anemic. Anemia in general, as like sort of a minor issue, is not a real big deal, but when it becomes severe, it can cause really big problems. So it is important to avoid becoming anemic if at all possible. If you become anemic, you should definitely get that resolved as quickly as you can. There are various ways to do that, but if you catch it before it goes too far south, you can just take iron supplements. I recommend Blood Builder. Um, Iron supplements can be really hard on your stomach. So, you know, it can be challenging sometimes to find the right supplement that is more gentle, but that's the one that worked for a lot of people that I know and that worked for me. The other big deal thing that happens in maternal nutrition is folic acid. So folic acid is really, really important in neural tube development. So there's some diseases that can occur in fetuses and in children that are related to folic acid. And really, like, folic acid is one of the main reasons why it is important to take prenatal vitamins, not just while you're pregnant, but before you're pregnant. And let me just talk about prenatal vitamins for a second. So in general, we don't really need to take vitamins unless there's like a specific reason. But when you're pregnant, you really should. Again, it is very difficult to become, or very easy, sorry, to become deficient in things when you are growing a whole extra person. And so prenatal vitamins help you make sure that you have the correct amount of vitamins and minerals on board so that you can start building that extra person. The reason why you start them early is because, very simply, we usually do not know we are pregnant until we are quite a ways into the pregnancy. And so you don't want to wait until you know you're pregnant because you've missed some really important moments of development for your embryo and for your fetus. Okay. I just want to hit the craving tip at the bottom. If you have a craving, if you are hungry, the first trimester can be very difficult because you're often the hormones in pregnancy will make you nauseous. And they don't have to, but they do for many people, and those hormones dissipate in the later stages of pregnancy, but the first few months can be really rough. If you are hungry, you should eat in the moment that you feel like um, there's something that sounds good to you. Um, Try not to worry too much about what it is, so much as it is that you are eating. Nutrition is important, proper nutrition is important, calories are the most important. So if you're hungry, please eat. Fed is best. And you know, I can't tell you how many meals got wasted because instead of like getting DoorDash or something, like I waited for takeout to be brought to me while I was pregnant. It's a terrible idea. By the time I got it, I didn't want it anymore. So feed your body when it is hungry. Okay. Teratogens. Okay. So teratogens are toxins that will harm your developing fetus. And they fall into multiple categories, but medications is one of the major ones. The FDA has categories specifically for pregnancy around the medications, whether you should use them in pregnancy or not. They are A, B, C, D, and X. Essentially, category A is like safe in pregnancy. We know it's safe in pregnancy because we've tested it on pregnant people and, in a scientific way, we've tested it on pregnant people. B is more or less, we know that it's safe to take because we have lots and lots and lots of evidence that it is safe to take, and there hasn't been anything that has popped up that tells us otherwise. I'll come back to C in a minute, but D and X, don't do it. If there's any way to avoid D and X, you should avoid them. X especially, I mean, there's a reason why it's X and not E, right? But like X especially, that would be like your thalidomides of the world, right? So C is a tricky one. Okay, so category C, if you have a medication that is category C and you are thinking about becoming pregnant or you are pregnant, do some research, like look it up, like go find the actual research involved in that medication, because often what you will find is that that medication is toxic to the fetus at a certain point in pregnancy, but not any other point in pregnancy. So it's like toxic in the first 3 months or the last 3 months, but not any other time, whatever. But that research is out there, right? If it's in category C, we know there's a problem. So the evidence is out there. Often, I will tell you this, often the doctors will say it's in category C, you shouldn't take it, or it's in category C, it's not great, but go ahead and do it. But there's nuance to category C medication. So like make sure that you go figure that out. Yeah, okay. Okay. So teratogens, there are some of the most dangerous teratogens are also the most easily avoided ones. So these are the things that you find in kind of everyday life. Alcohol, tobacco, cocaine. Well, I mean, I don't find cocaine in everyday life, but some people do. Pretty much all STIs. I'm going to talk about herpes specifically because that has a specific situation. Rubella, and Zika. So alcohol, let's talk about alcohol. So you cannot unsee this once you see it on people. So like, the area below your nose and above your lip is called the philtrum. And when there's no groove in the philtrum, I don't know of any other thing that causes this except fetal alcohol syndrome. And so that's basically the face and the brain are developing at the same time. And when strongly affected by alcohol, this is this is an outward effect, but there are lots and lots and lots of effects on the brain. Folks who were born from mothers who did a lot of drinking, and so they have fetal alcohol syndrome or fetal alcohol effect, which can't really usually see visibly, but they have a lot of issues, frontal lobe stuff, right? A lot of impulse control issues, behavior issues, that sort of thing. Really avoid alcohol in pregnancy. There are points in pregnancy where it doesn't matter as much. Um, kind of your first trimester is pretty critical. Like just in general, avoid alcohol in pregnancy. A lot of people will tell you like a glass of wine is fine. A glass of wine probably is fine. I will tell you, I did not go anywhere near alcohol while I was pregnant. Tobacco has all sorts of problems for unborn children. Among other things, it causes low birth weight, which has all sorts of long-term health implications. Cocaine also lots of issues, low birth weight, withdrawal, all sorts of ugly stuff. STIs. So a lot of the STIs can cause problems for fetuses. Some of them will cause stillbirth, among other things. Herpes is a special case, and I want to highlight herpes because so many people have it. Like, I think the latest statistics that I read was like 70%, 70% of the sexually active population has herpes. And you're like, what? What are you talking about? That means 7 out of every 10 people in this room has herpes. Yes. So, basically, th- um, most people who have herpes do not know that they have herpes. If you have had more than one sex partner, you probably have been exposed to herpes. Most people are exposed in childhood. Most people are not exposed genitally, but the problem is when you have a herpes outbreak on your genitals and you try to deliver a child genitally, you can pass herpes on to the child. And that's not just a problem because herpes is bad, but it causes blindness, among other things. So like, if you have herpes or if you think you might have herpes, um, and you need to talk to your doctor about that, because they will give you medication to suppress the I think it's virus before your due date so that you can give birth vaginally without the risk of passing it on to your child. If you do have an outbreak, you should have a C-section. It does have really serious implications for the unborn child. Rubella, similar, very serious problems for the child. There is a vaccine for rubella. You should absolutely 100% get vaccinated. It is not worth getting rubella while you are pregnant. You could lose your baby or worse. So, Zika causes really, really serious birth defects. And you might have heard about that. Some years back, there was a lot of Zika activity. Zika is pretty much wiped out in most developed nations, but it's not gone. So, yeah. Okay, physical trauma, story time. Okay, so in 2018, in late 2018, I was riding a naughty horse and he bucked and I broke my back in 4 places. And I didn't know that my back was broken, but I found out when I went to the hospital. And basically I broke 4 vertebrae. I put a helpful little red box around the vertebrae that I broke so that you could sort of visualize what the situation was. And I went to the hospital and the doctor said, "Is there any chance you could be pregnant?" And I said, "I suppose maybe." And she did a blood test and she said, "Congratulations, you're pregnant. I need an x-ray anyway." And I said, okay." And she said, um, "Well, either everything will be fine or you will not be pregnant anymore." I said, "Oh, okay." So that's what happened. And I did the x-ray and um if you've ever had an x-ray and you are a person with a uterus, you have been asked if you are pregnant. And I did some looking into this for this lecture, and I just want to point out that the risks to the pregnant woman of not having imaging or a particular procedure that's a problem for a developing fetus is far greater than the potential harm to the fetus. So let's talk about that. So for an x-ray, sort of your standard radiograph, you are exposed to about 1 rad, okay? But the evidence suggests that the risk really begins above 10 rads. So unless the x-ray that you requires more than 10 shots to get what they need, which, I've had my fair share of x-rays in the world, I've never had 10 shots, then there's very, 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 very low risk to you. So the CT is different, same kind of idea, many more rads. So ask about the number of rads related to any CT that they want to do. But very likely, if you are pregnant, they will find a different way to figure it out than to give you a CT. Oh, so the peanut butter and jelly sandwich, why is that there? So I want to talk about, for physical trauma, I want to talk about the placenta. So like I think that this comes up on the next slide, but I'm going to talk about it anyway. So the doctor said to me, I was turned out I was about 3 weeks pregnant. And the doctor said to me that in the embryonic stage, so that's like the very beginning stage of being pregnant, and there's no placenta, the egg is basically just implanted directly into the uterus. The the way that you should think about it is basically a grain of sand in the middle of a peanut butter sandwich. You basically have to destroy the sandwich to harm the grain of sand. And I have to say, I found that very reassuring. So yes, so this is the next slide. So until the placenta develops enough to be dislodged with trauma, that's around 20 weeks, it's there's pretty much no external trauma that can harm the baby. So without killing the mother, essentially. I mean, I'm sorry, but that's the situation. So it's about 20 weeks, and the placenta is attached in a very non-foolproof way, unfortunately. And, like a serious jostle really, really is a problem. And we're not talking about like, running down the stairs. We're talking about falling down the stairs. You know what I'm saying? And as the fetus gets bigger and there's less space in there to kind of like maneuver, the risks of like taking a fall are greater. So placental abruption, so that's the detachment, full or partial, of the placenta from the uterus, is a leading cause of death for mother and baby. They will bleed to death, right? Internally, mother will bleed to death and baby will suffocate, essentially. So like it's a very, very serious issue of placental abruption. Um, yeah, so that's why, for example, you're not supposed to ride a roller coaster when you're pregnant. Now, if you are 4 weeks pregnant, it's not going to make any difference. It's not going to make any difference. But if you are 4 months pregnant, so that's 16 weeks, or 6 months pregnant, that's 24 weeks, right? Like that's a different situation, and you should not go anywhere near that enjoyment. That can wait until after the baby comes. Okay, so the baby has arrived. Attachment. But wait, before we get to that, we can't talk about everything tonight, but I do want to touch on a very important and controversial topic. Breast is best. So, the breastfeeding lobby, essentially, says that breastfeeding transfers all these antibodies to the baby, and that is true. But the effect of that, especially after 4 months old or so, are pretty minimal. So, like, yes, that's the breastfeeding is good for the immune system, but fed is best, and babies do need proper nutrition. But formula and breast milk both do that, and parents need sleep, okay? And sometimes breastfeeding can be very disruptive to a family, and it can make everything else difficult. Also, if you are breastfeeding, the other parent or the sibling of the baby or whatever does not get a chance to feed the baby. So that's bonding time. And the process of breastfeeding and the logistics of breastfeeding can be quite challenging, especially if you work outside the home or you have a lot of other responsibilities. So, like, do what's right for you, but don't let anybody bully you into thinking that you have to breastfeed. Or on the flip side, if you can't breastfeed, that you're somehow less of a parent. The baby's development isn't different either way you feed, okay? But it definitely will be different if you, the parents, are exhausted, frustrated, in pain, right? So like that changes how we respond to our children. It changes how we respond to each other. It has all sorts of implications for relationships. It's just bad news bear all the way around. So it's really important that we prioritize the overall well-being of the situation as a whole and not blow out of proportion the benefits of breastfeeding over formula feeding. I see a lot of people getting very upset about not being able to breastfeed, and it just makes the whole situation worse, like putting this pressure on other people to do something that might not fit well with their family is just, it's a shame, really, because it's nobody's business except that family. Okay. All right. Attachment. The baby has arrived. Okay, what is attachment? So we are biologically primed for attachments to one or more primary caregiver, and that's the person who provides for our biological and emotional needs. Without at least one specific caregiver to bond to securely, we develop attachment disorders. These disorders are not destiny. They can be changed, remember neuroplasticity from last week. But if they go unaddressed, they can continue to become a problem as an adult. And we're not just talking about romantic relationships. We're just talking about like relationships with other human beings. Okay. So the video I'm about to show you is designed, typo, for students who are going to test about this topic for their A levels in England. That's kind of like AP classes. So it gives good advice for essay writing, but I don't expect you to get it in your notes. I think that you know, the video, well, it's not on Canvas, it's right here, but like you want to make sure that you understand what's in this video, but you don't really need the essay writing bits, if that makes sense, but it's really good information. Okay, here we go.
Right guys, welcome to attachment lesson 7. In this video we're going to be looking at types of attachment and the strange situation. As always, we'll spend a bit of time on the outline first before going on to the evaluation points, and then we'll end with a 6-mark example outline which will set the scene nicely for any potential essay on this topic. The timestamps in the description will let you navigate to a particular section of the video if you're looking for something specific, but whether you're looking for something specific or not, a like would be amazing if you find this video useful. So, the strange situation was developed by a student of John Bowlby's called Mary Ainsworth as a method of assessing the quality of attachment between a baby.
You know what? I don't know why that's not playing, but that's okay. I will post that video separately and we'll get that sorted out. All right. Let's move on, and I will just post it in Canvas.
Right guys, welcome to it.
Okay, so hopefully you have paused the video and you've gone and watched the video from the previous slide. I'm sorry about it not playing correctly. There's some the 3 basic insecure attachment styles that that Mary Ainsworth established in babies are avoidant, ambivalent, and disorganized. And avoidant babies, they just don't show a lot of emotion. They're kind of like, okay, like they kind of roll with the punches, but in a oddly detached kind of way. The ambivalent babies are very clingy, and they get really upset when they get separated from their caregiver, but when the caregiver comes back, they're mad. Right? These are the babies that are like, no, I'm mad at you because you left, So this is a result of inconsistent parenting, and these are the parents who are not attuned very well. So these are the ones who are trying to play with babies who are trying to sleep, for example, or who are trying to have a dance party when it's bedtime, like that kind of thing. So disorganized, that's the lack of a clear attachment strategy at all, with the child showing like any attachment strategy that they can think of to try to get their needs met. It's really chaotic. Okay, so in adulthood, right, the avoidant style turns into something called a dismissive avoidant. And these are folks who emotionally distance themselves from others. They're not showing emotions, they're kind of suppressing them. They avoid close relationships so that they maintain their independence. They don't have to like lean on anybody. Those are the dismissive avoidant folks. The ambivalent babies have become anxious, preoccupied adults, and those are folks who really want to have that closeness in childhood. But they're feeling very anxious about it. They're feeling very insecure about their relationships. They're very worried about being abandoned or not being loved enough or not being, loved enough as they love the other person. And so they can be sort of clingy. They can also get really mad. So anxious, preoccupied people kind of have a tendency to display these things called protest behaviors. So they will they will show their displeasure about something that their partner has done by, these are the people who will slash tires, right? Like that's an extreme example, but these are those folks, right? And then the disorganized babies map onto the fearful avoidant adult attachment style, and that is a mixed style. So you use a little bit some of the strategies from the dismissive avoidant folks, where you kind of like, you keep distance when your feelings are hurt, for example. But if in the beginning of a relationship, when you're really trying to like get somebody to bond to you, you'll be kind of clingy and needy, and show kind of those anxious, preoccupied tendencies. So those are the fearful avoidant folks. Okay, so you're going to have an opportunity later in this semester to test for your adult attachment style. There's lots of online tests, but we're gonna use a specific one, but you can find one now if you want to do that. But I'm pretty sure that you have some sense of what attachment style you have. And I just want to point out, those are the insecure attachment styles. Like half of the population is secure, more than half, I think. So like they don't show any of those sort of uh, uh dysfunctional behaviors. I will say that we all have a primary attachment style as well as a secondary attachment style. So the primary one is the one that we use kind of in day-to-day low stress situations, and then the secondary attachment style is the one that will come out when we're under extreme stress. So just keep that in mind. But the point that I'm trying to make here is that we are neuroplastic, okay? So, even if half of the people in the United States are secure, the other half are not. But that can be changed, right? We can learn new strategies. We don't have to live the same way that we have always lived. We don't have to keep reliving our traumas from childhood. We can reframe our previous experiences and work through them. We are not stuck, right? So this is true for the children in your life. If you're listening to some of these descriptions and you're like, uh-oh, my kid is not secure, like this can be fixed, right? Like these, and for children, it's about kind of changing the interactions that they're having between them and their primary caregiver. So that requires the primary caregiver to make some changes, right? Um, but like children are even more neuroplastic than adults are. So like this is stuff we can change, guys. Like this is not something you have to just live with. So if you're feeling yourself and some of these, or you go out and you take an adult attachment style test, and you think, uh-oh, I don't have a secure attachment style. No wonder I have so many problems with my relationships. Like it can be managed. It can be dealt with, right? Like, so here's another recommendation. Thais Gibson. She has lots of books. She has a YouTube channel, which is really helpful. I will say that it is very easy to let your unconscious bias take over when you look at Thais, because she is young and she is beautiful, and it is very easy to not take her seriously as a psychologist. But believe me when I tell you, she is a very serious psychologist, and has a very good sense of people. So do not let your bias take over. It's really important that you don't. So, yeah, I recommend that you go and you find, if you're worried about any of this or thinking it through or want to know more or whatever, I highly recommend that you go find her YouTube channel. Her company is called the Personal Development School, and it is for profit organization. That doesn't mean it's bad. It just means, she makes some money from it. But the YouTube channel is free, of course. So like, yeah, I would start there. Okay. So helping strong attachments form. Um, Here's some like just tips about, forming good attachments. There is no such thing as being too responsive to a baby or young child. I think we have all heard people say something like, "Don't pick up that baby, you'll spoil them," or something. That is not a thing. Babies and young children do not have the capacity to self-soothe. Soothing is a learned behavior. We have to learn that by having somebody show it to us. There is something called co-regulation, and that's the part where you use your body and the like sort of your lower blood pressure and your slower heartbeat to bring somebody who is really upset back down, right? And that's what we do with babies. That's why we hold them to us when they're distressed. That's why our natural instinct is to hold them to us. Our instinct is to co-regulate. Okay, so always go to a baby when they cry or in distress. If it's a situation where you can't stay, try to make sure that the person that you're handing them off to will console them. So sleep training is a tricky one, right? Because when you sleep train a baby, you basically leave them to cry for a certain period of time. Um, this is one of those situations where you have to balance your sanity with, like what is optimal for the brain health of your child. Sleep is just as important, and in many ways much more important than being perfectly responsive to your child. And if your baby is staying up for hours and hours and hours and hours because you haven't sleep trained, that you're doing much more harm to that child than you would be to just like let it happen. So like, you're not going to break your kid either way. And part of the reason why you're not going to break your kid either way is because, you know, parental or rather caregiver responsiveness is never perfect. It is never a situation where you're always doing the right thing and you're always Johnny on the spot all the time. It doesn't have to be perfect. You do not have to hit a hole in one every single time you swing the club. That's just not life. It's about the majority of our interactions. You need to make sure that you're consistent and warm and responsive, right? You're just not going to be able to be there 100% of the time. Okay. Other tips for helping strong attachments form. Read their signals. If they're sleepy, don't try to play, right? If they're bouncing off the walls, don't try to force them to take a nap. Read their signals, be responsive. The more responsive you are to how they are behaving in any given moment, the more they're going to kind of like feel seen and attached to you properly. Okay. Use an authoritative parenting style. If you don't have those skills, seek a training program. There are lots of training programs out there for your parenting skills. So um it's so critical to parenting and our own self-reflection of how we're parented that next week's homework covers this, even though next week has nothing to do with development. That's what next week is going to do. Okay, so before we finish today, um, we're done, right? But before we finish today, I want to talk about the end of life. So we didn't cover um like adults at all, right? We're just talking about children today. But like there's a lot to adult development as well that is important. But what we don't talk about very often is the end of life. And the end of life process is one that obviously doesn't impact the individual very much, but impacts the people around them a lot. So I just want to put in a plug here in the development lecture for hospice. Okay. So I've been working in hospice as a social worker for, well, since I was pregnant. So like think about think about the um the process of starting to work with people who are actively dying when you're pregnant. So it's really interesting experience the way that started. But you know, hospice is designed to, it doesn't speed up a death, but it also doesn't slow a death down. All it does is make folks comfortable at the end of their lives, right? And there are lots of different ways to do that, and there's medications to do that, and there's social work support, and there's spiritual support, and there's, of course, nursing support and doctor support and all of that. But for folks who don't want to die in a hospital setting or don't want a bunch of life-saving measures done, hospice can be a very peaceful way to help people to die in a way that feels okay to the people that they left behind. Nobody's really gonna be like, well, that was a really good death. I don't even know what that means, honestly. But to die in a way where the people who loved that person can walk away and say, you know, I feel like they were peaceful at the end, or as peaceful as they could have been, is really good for their development. Is really good for those people who are left behind to move on with their own lives. So I just wanted to put in a plug in there because you have to go back into your chapter and read about adult and senior development, and that's fine. But I just wanted to talk about the very end of life. All right. So thank you so much. And if you have any questions, I'm here for you, office hours, email, Canvas, whatever it is. I'm happy to answer your questions. All right. Thanks so much. Bye-bye.